Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Dose-Intensive Response-Based Chemotherapy and Radiation Therapy for Children and Adolescents with Newly Diagnosed Intermediate-Risk Hodgkin Lymphoma, AHOD 0031, a report from the Children's Oncology Group by Deborah Friedman et al. My name is Christine Mautz-Körholz, and I'm Associate Professor of Pediatrics at the Department of Pediatrics at the Medical Faculty of the Martin Luther University of Halle-Wittenberg in Halle, Germany. I'm a pediatric oncologist specializing in the treatment of pediatric Hodgkin lymphoma, and I am Vice Chairperson of the German Society of Pediatric Oncology and Hematology Hodgkin's Disease Study Group and Scientific Secretary of the European Network of Pediatric Hodgkin Lymphoma Study Group. Pediatric Hodgkin lymphoma is a highly curable malignant disease when treated with combined modality chemo and radiotherapy regimens. In their paper, Friedman and colleagues report on dose-intensive chemotherapy and response-based radiotherapy treatment for intermediate-risk pediatric Hodgkin lymphoma patients. In 2009, Schwartz and colleagues from the U.S. Pediatric Oncology Group reported on the ABV-EPC regimen comprising doxorubicin, bleomycin, vincristine, etoposide, prednisone, and cyclophosphamide. This regimen has been designed to enhance treatment efficacy by dose-dense drug delivery, leading to a 5-year event-free survival rate of 84% in intermediate and advanced stage young patients with Hodgkin lymphoma. Involved field radiotherapy at a standard dose of 21 Gray was delivered to all patients. However, the number of ABV-EPC cycles could be limited to 3 for rapid early responders, whereas slow early responders received 5 cycles in total. Similarly, the German Pediatric Hodgkin Study Group are using the OEPA induction chemotherapy containing vincristine, etoposide, prednisone, and doxorubicin and the consolidation cycle COP, consisting of cyclophosphamide, vincristine, procarbazine, and prednisone, which is administered twice or 4 times according to risk allocation in intermediate or advanced stage patients, respectively. In the German approach, radiotherapy is applied to involved fields, and the standard radiation dose is limited to 20 up to 30 Gray in fields with poor response to chemotherapy. Both of these regimens are more intensive than the formerly used MOB, combining miclorhamine, vincristine, procarbazine, and prednisone-based regimens, or the doxorubicin, bleomycin, vinblastine, and dacarbazine-based ABVD, thus eliminating drugs with a high risk of secondary leukemia, such as miclorhamine. However, these currently used pediatric regimes are still less toxic than the BIACOP escalated, comprising bleomycin, etoposide, doxorubicin, vincristine, procarbazine, and prednisone, which is used with high efficacy in adult patients, for instance, by the German Hodgkin Study Group. In advanced stages, patients receive 6 to 8 cycles of this regimen, and radiotherapy is delivered to PET-positive residues only after completion of the intensive chemotherapy. The rate of secondary leukemia after such regimens is less than 3%, but still much higher than in the before-mentioned pediatric regimens OEPA-COP or ABV-EPC, most probably because of the lower cumulative dose of etoposide in the pediatric compared to the adult setting. The cumulative doses of doxorubicin causing cardiotoxicity is also kept below the critical threshold in pediatric regimes compared to BIACOP escalated and ABVD in the adult setting, and the gonadotoxic drug procarbazine causing male infertility could be successfully exchanged by dacarbazine as shown in the 7th German GPOH HD 2002 trial, which had proven the OEPA-COP-DAC regimen for boys as equally effective as the standard OPA-COP for girls. While comparing both pediatric and also the adult Hodgkin lymphoma trials mentioned, it is important to know that there are differing definitions for allocation to the so-called intermediate risk population. The German Pediatric Hodgkin study group would allocate all stage 4 patients to the advanced stage treatment group, but on the other hand, treat stage 2A patients in the early stage treatment group, regardless of bulk. Here, the risk group definitions of the US Pediatric Oncology Group and the adult German Hodgkin study group are more similar and thus overlapping. Although Hodgkin lymphoma is a disease which is exquisitely sensitive to radiation treatment, in the 1960s, radiotherapy alone was the treatment of choice for Hodgkin lymphoma. Soon it became evident that with increasing cure rates and increasing numbers of cancer survivors, delayed effects of treatment, namely cardiovascular damage and second cancers, were the late life-limiting burden for the sake of initially efficacious cancer treatment. Therefore, all pediatric Hodgkin study groups aim at reducing the radiotherapy burden by using intensive chemotherapy regimens, thus keeping the excellent cure rates at the 90% margin. The paradigm of response-adapted treatment to tailor therapy and to spare toxicity while keeping high treatment efficacy was followed by all major pediatric Hodgkin lymphoma study groups. Accordingly, Dörfel and colleagues in the 6th of the German trial series, the GPOH HD95 study, omitted radiotherapy in patients achieving complete remission after all chemotherapy in all risk groups defined by morphology criteria. Treatment results dropped significantly in the intermediate and advanced stage patient groups who did not receive radiotherapy. In their 10-year report on the HD95 trial, it could be shown that intermediate and advanced stage patients without radiotherapy had a progression-free survival of 69% and 83% respectively. In their HOD 0031 trial, Friedman and colleagues have designed a study with an early response-based treatment adaptation. After 2 initial cycles of ABV-EPC, rapid early responders achieving complete remission, mostly defined according to morphology criteria in computed tomography scans, and simultaneously negative PET. PET is an abbreviation for positron emission tomography, or gallium scans, were randomized to receive additional radiotherapy or not. All other patients, including the slow early responders, received involved field radiotherapy. Most importantly, the results did not differ significantly between irradiated and non-irradiated rapid early responders in complete remission, achieving 4-year event-free survival rates with or without radiotherapy of about 88% and 84% respectively. Nor did the PET result impact the involved field radiotherapy randomization in this cohort of complete early responding patients. This is the first randomized pediatric Hodgkin lymphoma trial showing in a large cohort of intermediate risk patients that radiotherapy could be safely omitted in patients who achieved complete remission after 2 cycles of intensive induction chemotherapy. However, it has been shown that visual PET reading has a high inter-reader variability, even when performed by experts in a central review facility. The currently widely used evaluation standard is based on the 5-point Deauville score, which uses the liver or mediastinum uptake for referencing the residual tumor uptake at an early response time point. It is agreed by definition that residual uptake above the liver background, which is called Deauville 4 or higher, is considered PET positive. The PET positivity definition of the older scores, using the mediastinal blood pool as a background reference, as performed in the present trial, is corresponding to less than Deauville 3. Earlier this year, Hasenclever and colleagues have published a quantitative PET evaluation method, the so-called QPET methodology, providing a semi-automatic quantification for early PET response in Hodgkin lymphoma, extending the ordinal Deauville scoring to a continuous scale. Deauville categories respond to certain QPET values. Thresholds between normal and abnormal response can be derived from the QPET distribution. Of the data from 898 pediatric lymphoma patients after 2 OAPA chemotherapy cycles on the first trial of the European Network for Pediatric Hodgkin Lymphoma for treatment of classical Hodgkin lymphoma patients, the EuroNet PHLC1 trial, a certain QPET value excluded abnormal response with high sensitivity. It would be interesting to know if the application of refined PET response criteria would have spared even more radiotherapy in the present trial population. The early response-based treatment adaptation is a big step forward, which has been excellently demonstrated in this trial. It opens up new strategies to reduce radiotherapy in Hodgkin lymphoma. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.